Good afternoon, everyone, and thank you for joining us today on Live with Noelle. I'm excited to bring to you the amazing group of professionals that are on today's show, and we are going to be discussing a very, very important topic that many across the country can relate to, and that's about nursing retention with a focus on critical care. So if you're watching, please tune in, let us know where you are chiming in from, and absolutely participate in the discussion if you're here. And I'd like to start off with an introduction, and we'll do a little bit of a roundtable and have everyone introduce themselves, who they are and what they do. So in my view and my camera, we're going to start left to right, and that starts with Christopher Hockey first.
Hi, everyone. My name is Chris Hockey. I am a pediatric cardiac intensive care nurse by training. Currently, I do per diem work at the Children's Hospital of Philadelphia, and I also am a clinical scientific director at the Janssen company.
Awesome. Colleen.
Hi, I'm Colleen Gordon. I am brand new to Johns Hopkins Children's Center. I work as a nurse manager in their pediatric cardiac intensive care unit. I have had the distinguished pleasure and honor of working with Chris Hockey as a brand new grad nurse in the Children's Hospital of Philadelphia CICU. It is the only care that I've provided to patients in my professional career. And also, I should probably mention, Gil turned me into the nurse that I am today.
Awesome. Patty.
Hi, everybody. I'm Patty Hickey, and I'm the Vice President and Associate Chief Nurse at Boston Children's Hospital. My current areas of responsibility include the cardiovascular program, critical care, and perioperative services. And my program of research really examines the attributes and the factors related to nursing retention and recruitment across the United States. Thank you.
Gil.
Hi, everybody. Well, and Shauna, thanks for putting this on. My name's Gil Warnofsky. I'm a pediatric cardiologist and cardiac intensivist by training. I've been practicing about 32 years. I do have to say that, well, I'll start. My areas of research have in clinical care have been long-term quality of life in children that have complex heart disease and taking better care of them in the ICU. I do want to say that when I started as an attending in 1988, Patty was in the position, I think, as nurse manager maybe of the cardiac intensive care unit, and I learned I learned at that time. I learned from the nurses, quite frankly, and many of the nurses were in place for a number of years. And they taught me so much of not only how to take care of patients with medicines and whatnot, but how to be in a collaborative practice. And that was definitely Patty's responsibility. So it's great to be on the show, especially with so many old friends.
Awesome. Thank you for that. And Melissa?
Hi, thanks for having me. I am a nurse practitioner in the cardiac intensive care at Children's National in Washington, D.C. I have been a nurse for about 20 years, and the past 17 have been focused in the cardiac ICU. I started there at Boston Children's in 2003 and have made my way to DC. I have worked as a bedside nurse, as a nurse educator, and now as a nurse practitioner. I'm also the director of our neurocardiac critical care program at Children's National. So thanks for inviting me.
Thank you. And my amazing co-host, Shauna.
Hi, this is an amazing group of panelists, Noelle. I just want to thank you all for being here today. I'm Shauna Elliott, and before I stepped into my recently entrepreneurial role helping organizations on culture and operations and business goals and strategy, I have 15 years of senior leadership in the healthcare sector and a real passion to looking at culture at a micro level. So certainly some of the things we'll drift into today, there is some inherent differences when you speak to cardiac care, critical care that are different than exist in other units. So I've worked with physicians and nurses and teams in those environments to work on how they can work together and look at increasing nurse retention, employee engagement scores, as well as providing the best and safest care possible. In addition, I'm a faculty member at University of Western Ontario, and I just recently designed an evidence-based healthcare leadership course and having fun teaching it, where we're starting to dive into some of these issues that we'll be talking about today.
Thank you, Shauna. Darren?
Thank you so much, Noelle and Shauna, for having me. My name is Darren Klugman. I'm the Director of Cardiac Critical Care at Johns Hopkins in Baltimore. After spending the first 10 years of my career at Children's National, where I learned what great nursing looks like from people like Jiggy and Melissa who are on this call, and I'm thrilled to be a part of this. My other hat that I wear is in quality and outcomes, where I run the quality and outcomes program for the Heart Center at Johns Hopkins, and that's also the area of interest of my research as well.
Fantastic. And Jiggy?
Hi, good afternoon. Thank you for having me. My name is Jiggy Shemek-Williams. Everyone knows me as Jiggy, so you might hear that often. I've had the privilege of working with Dr. Warnofsky, Dr. Klugman, and Melissa. I started out in neonatal ICU about 20 years ago. I did that for 6 years, and then have been with Children's National in Washington, D.C. for 14 years, which I have just grown to love that institution and continue to grow my practice there.
Fantastic. Well, thank you, everybody. I really appreciate everyone's time and thought for coming on the show today. And, you know, as we start to dive into what nursing retention looks like, there was one question that has popped up when I talked about this group coming on, and it was from many nurses, the interest in physicians having a curiosity of why are physicians interested in nurse retention? And I think it's a fantastic question. And, you know, and I really have to give a kudos and a shout out to Gil, because as I started doing these shows roughly about 6 months ago and talking about my journey and where I've gone, Gil brought up the question. He's like, well, what about us? I'm like, well, what about physicians? What, you know, so there was this stigma of why would physicians be interested in nursing retention? So I'd like to turn it to the group of physicians here today and talk about what your interest is in nursing retention and how can a physician impact the retention of nurses?
Since you said my name, I guess I'll start. Well, I guess, you know, in the big picture, I think about it as team retention in general. And, you know, in terms of being a cohesive team, we don't want to have significant changes in the staffing, changes in the culture, as Shauna was saying, changes in the approach more than we need to. Now, you always need injection of new blood, new ideas, new grads, all that sort of stuff. But having a cohesive long-term team is crucial. And as it relates to nursing, as I said at the beginning, when I started in '88 in Patty's unit, I thought that was the only model that existed because it's the only place that I was. And, you know, the nurses were adjusting the ventilators, and in pediatrics, this was not all that common, titrating the drips, and working as independent practitioners as opposed to task-oriented stuff. And I learned that was the best model. And, you know, there are nurses there 30 years later now that helped me start my practice. And I don't think there's any question that that type of experience impacts not only my day-to-day enjoyment of work, but also impacts outcomes. And Patty's done the seminal research on this, and I'm sure that she's going to talk about that. So in terms of team cohesion, in terms of enjoyment of coming to work, it's your second family. Most of us spend more time there than we do awake at home. And in terms of outcomes in particular, it makes a difference. And the last comment I'll make is that to think that these retention things happen in silos is far too simplistic. I definitely know that docs can clearly screw it up, especially for young nurses, with ego, with volume, with lack of interest. So if you take the assumption, stay as long as possible.
Right.
It's absolutely our responsibility, and I think it's the responsibility of nurses to work with physicians at their level of job satisfaction as well. So that's what I would say on the topic.
Absolutely. And it's definitely an area of opportunity we need to start seeing more within organizations, is looking at that RN to MD partnership. We talk about the words collaboration often, but what does that look like and what does that mean? And, to develop that partnership and to actually see you and Patty on here after many years together and being—
Don't say the number too often.
I won't. But being where the both of you are at now is honestly, it's its own example of how important that physician and that nursing relationship is. Darren, from your standpoint, give us an example, and what are your thoughts about the physician intake in nursing retention as well?
Yeah, it's a great question, and I think it's one of the things that I think physicians who don't recognize the value in this are quite frankly, I think, being a bit short-sighted and have missed a huge opportunity. I say frequently that our care is only as good as the nurse at the bedside, and in cardiac critical care, and certainly in pediatrics more broadly, there's ongoing conversations about the challenges that we have with nursing retention. And I think when we look at it as a problem to be solved by nurses, I think that's in part why we are challenged the way we are. And as Gil said, this is a team sport. And I learned more growing up as a trainee and as a young physician from nurses than many other people that I learned from. And, the impetus to train people as physicians is often focused on residents and fellows, et cetera. Mm-hmm. I think one of the things that I've intently focused on in my prior job and in my current job as well is untapped opportunity to promote nursing retention in ways that are very easy and in ways that really promote passion and commitment to not only the profession, but to the unit that folks work in. Because there is a career, and there should be a valued career in being a bedside nurse. And that responsibility in doing that is the job not just of the nurses, but the physicians. So just as an example, one of the ways that I've tried to do this is by setting up a model where all of the project work, all of the process development that goes on within the unit is done in a shared manner with a nurse and physician lead for each of the projects, and included when possible with nurse practitioners as well. That provides a number of opportunities. Number one, it provides ownership, which makes people prideful and committed. It makes people really think about ways that we can improve care for the patients. And furthermore, which I think goes a long way to career, sort of fulfillment and also longevity, is it provides a very meaningful and easy way for us to provide nurses and others who are often not thought of for these opportunities to make scientific contributions to the field, both from a perspective of writing manuscripts, giving opportunities to present at national meetings, giving opportunities to speak. And those opportunities are ones that should be created and are the responsibility of the physicians as well. And I think that setting up a model like that really, I found to be very useful in my prior job, and in my new job now, where we're building a new program, is one that Colleen and I are working together to promote as well. And I find that to be particularly successful.
That's fantastic.
Noelle, do you know if it's possible for me to share my screen for a second? Is that doable?
I think so.
If I just want to close this particular part, can you see that quote by Bernie Lown there?
Yes.
Yes, I can see it. I'm not sure if the audience can, but we can see it. There might be a delay in the.
Yeah. So I just wanted to show this. A friend of mine. I'll just I'm sorry, let me just get this back on. I apologize for
No,
this,
that's
but
okay. That's okay. And if you want to
Bernie
save
Lau,
that and share that, go ahead.
yeah, this is, I'm not sure if that's going on, but Bernie Lown is a very famous adult cardiologist, has written a lot of the textbooks, and he published a paper now 52 years ago, where he said in hospitals equipped specialized adult cardiac units saved lives. But one of the most important things he said in that paper was this. He said, neither monitors nor the most complicated electronic gear makes a coronary care unit. The fundamental ingredient is a properly indoctrinated nursing staff. The reason for this is obvious. The nurse is usually the only trained medical professional at the bedside during important clinical events. And in fact, many well-functioning units have been successful because of the elite spirit, and competence of the nursing staff. It's one of my favorite quotes, and I don't think it's as well attributed to Bernie as it should be. So
yeah, I love that. Thank you for sharing that. And we'll make sure that we get that on the clip as well, and we'll share that in the repeat too.
I'll send it along to you.
Yeah, that would be fantastic. That's very powerful. And, you know, as we start to look at the feedback from the physicians, it does bring me to, you know, a different light in what that looks like. And I'm going to, you know, look towards Patty and the nurses who have worked with the teams in regards to the retention and what retention looks like from a nursing standpoint, because we do keep track and trends of turnover. And Gil, you're right. There are situations that come up where there is such thing as nursing burnout due to their physician interactions that they have in certain environments. And Patty, I'd like to focus a little bit on your successes and any you know, pearls of wisdom you may have looking at the retention and also the recruitment with nurses coming into the organizations.
Sure. Thank you for this opportunity. I'm really dating myself when Gil brought that article up. I was a new graduate at the Peter Ben Brigham Hospital, and Dr. Bernard Lown often made rounds, and it was the Levine Cardiac Unit at the time. So that was an incredible learning demonstration project for me. One of the themes that I think we'll hear threaded through this conversation is the obligation for us as leaders to role model from the bedside to the boardroom, that nurse-physician collaboration. Because as has been mentioned, this is a team sport. We all have the same goal for optimizing the patient experience and outcomes. And I think for new staff, we have an intergenerational workforce now, and different things matter at different ages and during different stages of your career. But one thing that transcends all of these generations is respect and a culture of collaboration and inclusivity. And I think that is a basic, fundamental human, regardless of profession, experience that is quite applicable to this line of work. And it is our obligation to help create and sustain these environments that are helpful and respectful to the entire team. This is incredibly hard work, but it's also incredibly satisfying. And to help nurses find joy in that work, nurses want control over their practice, but they are full partners with physicians in this work. So that's huge.
Thank you for sharing. And if you look at some of the work around nursing retention, and we, you know, to really bring it back to the bedside with staff, and I open up this question to, you know, everyone on the panel. What has been one of the key measures that has worked successfully when we look at nurses understanding what retention is, what does it mean, and what are they doing at the bedside to retain their staff? I bring this up specifically, and what comes to my mind is when you start to look at preceptor burnout and new grad nurses coming in, their thought is always there because you want to raise and create your own, but oftentimes some are precepting 2 years in a row, and there becomes this burnout feeling from new nurses coming in. So, you know, I'd like to ask the group, when we start to bring retention to the bedside and have them understand what that means and the impact that they have on that, what type of initiatives have any of you done to really instill the value of retention with nurses at the bedside?
So Noelle, I don't know that I have a specific initiative, but I have sort of a practice that I think is important to retention, which is that when I look at my own career and what has kept me in this sort of line of work, is that I find meaning in my work, and that meaning evolves. So it's different when I was a new graduate nurse. It was different when I had 5 years of experience, and it's different now, and I expect it to be different in 20 years. Maybe if I'm still doing this. But I think that one thing I both look for and I try to assert with new nurses is to inspire meaning and help them find some depth in their practice, so that, you know, it's not just about turning knobs on a ventilator, or it's not just about learning how to titrate vasoactives, but it's the art of talking to families. It's recognizing the impact that you have when you role model good interdisciplinary behavior with your physician colleagues. That you know, nurses, I think and I talked about this a lot at our nursing shared leadership meetings. Nurses are such informal role models, and I don't always know that that's articulated or appreciated. And so I think that nurses sometimes undervalue what they bring to their team, because we sometimes don't recognize how impactful their ability to role model behaviors is. And I'll give you one example. So Jiggy is one of these types of nurses, I'll just say this, but there's like a cohort of nurses that I work with, and my focus right now is on neurodevelopment. And these nurses will respond to low cardiac output syndrome, prioritize interventions. You know, they are critical care nurses. They're going to get this done. But when I see those same nurses bathing and dressing a baby and carrying them around the unit while they're on milrinone waiting for a transplant, that's when I feel like you found meaning. Like, you have found some depth to this job where it's beyond the tasks. And not only are they inspiring their colleagues, but they inspire me. They inspire all of us who are watching this sort of behavior and this practice that I think brings meaning to everybody around them. So that's one thing that I sort of think about when I think about how to keep nurses at the bedside, is to sort of inspire meaning.
And that in itself, you know, just shows the value of retention without even talking about it. It's the authenticity of their work that they do, and it just, you know, that's what creates the healthy work environment, and those two really do and shall follow. And, you know, you bring up such a great point when I look at, you know, ICUs and burnout, and, you know, previously in my past life, we turned a pediatric ICU into a COVID ICU, and our outcomes with these adult COVID patients in the PICU were fantastic. We had some of the best outcomes in the hospital, and it was because of those reasons. It was that human touch. It was still giving them the spa baths, the music is on, you know, it's all of these intricacies that go into what a pediatric nurse does into patient care that creates a fantastic outcome. So thank you for sharing that. I want to sort of take a pause on us and look back. We've got a lot of amazing people in the audience that are chiming in right now. And let me go back through. So I've got Jenna Drevins, who's here today. We've got Frankie Gilliand, who looks like he's coming in from Florida. Jan is coming in from Baltimore, and they're all very engaged in the conversation. And so, asking the audience too, I appreciate the comments. If there's anything that reflects in the conversations that you might have a question for the panelists, please let us know. We would love to hear your thoughts in on the discussion as well. So yeah, I'll turn it back to you guys. Shauna, any insight on the conversations we've had so far?
Oh, it's been fantastic. And I do have a number of questions. So it sounds like in the experience of our panelists that you are working in very healthy and positive cultures. Unfortunately, my experience has been, when I was getting into organizations where cultures were not as evolved as to what your experiences are today. And then I have been recently pulled into organizations that really do need help and support in the spaces we're talking about. So I like to maybe start with Patty, and physician and administrator relationships has always been a journey from a collaboration, from a not so collaborative environment. And certainly at the top in the boardroom and at the senior leadership table, how that is modeled, to your earlier point, is really essential. And so the organizations I've supported, it's been one of the root cause issues in regards to the cultural issues that do impact both nurse and physician retention and engagement. I'm curious, if you've ever had any struggles yourself in your career to that end, and then what you've done that kind of help build those relationships and really fostered a collaborative environment. And then if you haven't, given, because you've worked with some really collaborative physician leaders and physicians, what advice can you give to administrators as to how to build that relationship and then to start to step into the shoes of physician leaders so they can better understand the dynamics that they're living in, their challenges? So in my experience, I say a lot of time that they're just judged and it's just physicians and whatever that story is, but to be more empathetic and better understand their challenges, to see it through their eyes so that partnership and relationship can be built.
So in that question, you raised some really good points, and it is the marriage of science and empathy. And for each discipline to understand and to help each other walk in those shoes. I think an example of something that we have been able to launch over the last couple of years that has really helped bedside nurses and hopefully has mitigated moral distress, which is a national problem, whether you're a nurse, a physician, or an administrator, is what we call the NEST program. So long story short, at any given time, 24/7 at Boston Children's Hospital, I can be sure that if a nurse in the critical care unit has an issue and is struggling with a problem, that they can get just-in-time coaching and support by somebody who we have given dedicated time to. And the differentiator is this is a very experienced nurse. So it's different than an organizational approach. We all have offices of clinician support, and you can call and get an appointment with a psychologist or a therapist in a couple of days or a week. But what we thought the gap was that just-in-time support. How can I be helped now? We all know that if we suppress those struggles and those feelings, they come out in all different ways later. And this has been such a successful approach that the physicians have asked for a NEST coach. And so our job is to make the case to administrators to understand that this is a real need, as important as volume, outcomes, and everything else that we measure, is how do we ensure the right staff are supported during the most critical times when they may be struggling with a situation. And these situations in cardiac critical care come up all the time. So that's an example of a program. Yes.
I wanted to follow up Shauna's question to drill down on something, which is, and I think Shauna, you asked at the very beginning, how do you get the collaboration started? How do you get buy-in from the physicians? And to Patty's work, I mean, Patty, if you could summarize a decade or so of research, what's the data showing on nursing retention and reduction of mortality? And nursing experience and the reduction of mortality?
Nursing experience.
I think I'll just finish, to get the collaboration going, most physicians want the data before they get into the next steps as to, or administrators, why is it important to spend the money on this or the time?
So we have shown across 43 children's hospitals in the United States that experience does matter to mortality and complications in cardiac surgery patients. And in those units with larger percentages of nurses with less than 2 years of experience, the mortality data is not as the, I don't want to say, the results are less optimal. And we have published that in 3 different administrative data sets. So while the message is not, we don't want nurses with less experience, we need to recruit new graduates and support them through at least the first 2 years of experience so that they can gain that experience, which is critical to patient outcomes in terms of mortality and morbidity.
Yeah.
And that's in a bullet, the outcome. But we have publications that go into the detail.
Well, I think the data, to your point, Gil, is essential. In my experience with working with physicians and understanding what they need to help understand where their role is and how they can be part of the change, it is all on the data and succinctly presenting it. You have a very small window of time to be able to make your point and to be able to engage them. So I think that's essential. The NEST program, Patty, I was just having a debrief with a client last night on a significant issue in their emergency department, and I was asking, where are their debriefing programs, what support, and they had nothing in place. So to even get to the NEST program that you've mentioned, I mean, it's many hospitals don't even have the basic support, let alone what sounds like an amazing asset for your team. So I'm really glad that you referenced it. And then I guess I'd like to ask Darren and Gil from a physician perspective. And again, it sounds like you're working in cultures that are already, designed with the right support to foster collaboration. And in my experience, I've come at it from the other side where it's already a significant issue for a whole host of problems. And I found my own techniques to be able to partner with physicians and understand the challenges, and then do the same with nursing staff and the full team, because it is the full team that really does influence the culture. But I'm curious, when you have physicians or you're talking to your peers in other organizations who perhaps haven't had the same focus as in your departments or your hospitals, how do you have that, what is it that you say to them when they're in the thick of it and they may be in a toxic environment, which there are plenty out there? How do they, as a physician, begin the conversation to begin the change? And they may not be in a physician leadership role. And so how do you start to plant the seed? Certainly you're modeling the way. You have lots of examples of success, but it could be a rural hospital. It could be a mid-sized community hospital, and not the same setup or the same view on culture from the top. So what recommendations would you have to those physicians who understand retention is really key for nurses and collaboration, but yet they don't know where to start to help be the voice of change?
Shauna, that's a great question, and I think it's one of the things that people struggle with a lot. And Melissa hit on this before, and it's something that I talk about a lot, which is the recognition that everybody is a role model, regardless of what your position is in the leadership, from a leadership perspective, or if you're a new grad nurse, or if you're a new faculty person. We all have the ability to influence the culture and around us. And the culture around us might be in a boardroom, which is filled with leaders, or it might be at the bedside where you have a physician, the bedside nurse, and a family member. And the culture develops based on these small interactions that people have. And it's the opportunity that it's our job as leaders to make sure that everybody recognizes that our contribution to the culture starts the minute we walk through the doors of the hospital. And that is in part why that's another secondary gain of promoting nursing retention, quite frankly, is that it promotes pride not only in the unit, but in the organization. And when you have people feeling that way, which Melissa was talking about before, it really empowers them to take those opportunities to lead and take those opportunities to role model. And I think, I can talk about this a lot, but the truth of the matter is a lot of this starts with the nursing leaders also talking about the importance of that collaborative sort of care model. And I'm to work with exceptional nursing leaders, not just at the bedside, but in unit management roles. And Colleen, who I'm working with now, is doing a phenomenal job as we've transitioned to a different care model, as we've opened up a new unit, and we've had challenges with COVID, which have necessitated us opening up additional units. And I think Colleen would be a fabulous person to speak to how a nursing leader does this and how a nursing leader promotes the importance of that collaborative interaction and those small instances which go a long way to influence culture. We only have one opportunity to do it right. And if you don't do it right as a physician, unfortunately, with the hierarchy that exists in medicine, you often have a very hard time recovering from that.
Well said.
So
Yeah, I guess
Go ahead, Colleen.
Oh, go ahead, Colleen, you go first. I was going to make my comments too.
Sorry, Gil. It's not often I get to cut you off.
Take advantage of that opportunity.
Wait a minute, that is so not true. That is absolutely not true.
Yes,
nobody knows that.
And as you say that, once Colleen finishes, I would like to also hear from Chris and Jigisha, who are on as well, my silent friends, to get their input on the conversation in this group that we have. Go ahead, Colleen.
So it was it was an interesting situation that I walked into when I first took this job. 2 weeks after my first day on the unit, we had our official ribbon cutting. And so I literally hit the ground running, which I think in critical care is kind of what you're used to doing. I barely had an opportunity to figure out people's names. We barely had a plan for nursing and for staffing, but I make it a point to schedule time in my day to be present and available on the unit. So people are constantly aware that I am here and that I am involved and that I know, the care that the patients are getting. And Darren and I schedule time as a team to walk around and do that as well, so that people see us together and as a team ourselves. But the biggest change that I think I had seen, pulling the cardiac patients out of the PICU, sort of fractured a lot of those relationships that not only did we have as a cohesive unit, which we were technically not anymore, but also those relationships and friendships for the people who had left the PICU to specialize in one organ as opposed to the MASH unit that the PICU is. And there was a reason that people wanted to leave the PICU, and I gave them the opportunity to pick their own code of conduct, really. Like, how do you want to be treated? How do you want others to be treating you as well? We didn't put anything on paper. People just did it. I empowered them to say, it's okay that we can disagree. It's not okay that we treat each other like crap because of it. And within 2 weeks, literally just saying those words to people, it is okay to be treated the way that you want to be treated. Within 2 weeks, I started getting unbelievably positive feedback from nurses in other units who were sharing time in the CICU because my staff was so supportive. They were so helpful. They were so approachable. And it just took 2 weeks. This is my first nursing manager position. It is not my first management position. Prior to coming here, I managed the admissions department at Children's Hospital of Philadelphia. And the requests and the needs from both staff, non-professional support staff and the nursing staff, was the exact same. They had all of the same wants and needs. And it was basically, I just want to be appreciated. I want to feel like part of the team. And I want to have a say in the work that I do. And so nicely, having come from a position that had a little bit more tension and a lot more fractured, who felt like a silo within this large organization, coming here and hearing it really sort of flip that light switch for me, that this is not specific to nursing. It is not, people want to feel valued. They want to feel part of a team. And when you give them the opportunity to do it, they'll do it.
Mm-hmm. Fantastic. I'm going to give you literally a round of applause for that one, Colleen. I mean, you have brought nursing, you've got like servant leadership into that. You've brought transparency into that. And it's so important for staff to hear, look, this is what it is. This is what we're looking for. Concrete, goals, concrete expectations, I think is so valuable when you're starting off new to that, because you either have it, you want it, or you don't. So there's the willingness to that, right? A question did come in from the audience from Rhiannon, who said, and this goes back to the NEST program for Patty, who is it that provides the real-time support for staff through the NEST program? Are they internal or are they external? And this program sounds great.
So they're internal. I was just typing my response. Thank you for the question. Oh. They're internal, experienced critical care nurses who must interview for this role, because I think we all know some people think they're really good at supporting, and people are, that's not helpful. So this is, each unit interviews the person, and they do this for one shift a week. So they are practicing critical care nurses who have that credibility, who we make sure are interested in this, and we give them the support as far as education at the Harvard Bioethics education course and other conferences that they can attend, to make sure that we're supporting them to do this role, because this is also a very difficult role with and it's one shift a week per person. So they do that while they're practicing.
That's fantastic.
But it's protected time during that shift that they're carrying the nest beeper. Yes. Thank you.
Fantastic.
And we have a publication coming out. I can send you that link. Thank you.
Yeah, please share that. That would be wonderful. Would love to see that.
I see Gil's hand up on the screen, so I don't know if Gil's got a question. If so, we'd like to hear that.
You're on mute.
A comment for what Noelle said, and then I wanted to ask Chris just a quick question. And you sort of asked, what are the physician roles in helping with nurse retention? And I think it'd be a good generalization to say that if you're a good surgeon or a good intensivist, you think you know how to do everything, which of course you don't. And I think having the physicians ask the nursing leadership and the bedside staff and everybody in between, what can I do to help? Asking the question. And you find, as I think people have said on this, that, what the relatively new grad needs in terms of just-in-time training and graduated responsibility is very different than what a more senior person may need in terms of education and support. I had a real privilege of working with Chris a long time ago. And what's impressed me about Chris is that not only has he gone off into a different life, a different type of position, but has kept doing per diem bedside nursing because it keeps that fresh. So people may leave your unit, but how do you keep somebody like Chris to come back and stay involved in the pool? So I'm curious, Chris, what led you to your dual responsibility? Because I think it fits in well with, you don't want to lose somebody for 100%, but if you can keep them for 20% and a lot of years of experience, that's a good way to go in between.
Thanks for the question. Well, you're the reason I left the bedside. So I just remember, I don't know, 20 years ago or whatever it was.
Better or worse.
you asked me to, well, the first time I met you was when I was shadowing, when I was first interviewed and I shadowed, and you walked up and you introduced yourself as Gil. And after you walked away, I said to the nurse I was shadowing, I said, is that the nurse manager? And she's like, oh no, he's the director. And I'm like, oh, she's like, he's the MD. I was like, well, he just said his name was Gil. So it's that starting at the top, right? Starting at that point, you didn't know me. You made it a point to be blind towards me because you wanted to know me. From that point on, it's that interaction having with the physicians and the other nurses, that it's very collaborative. There's always teaching moments. I could just remember the rounds when I was doing it full time, is that it was so important to get us to understand and know and be able to respond to that. So we are there in your eyes and ears, but at the end of every round, I remember Gil specifically, anything we're missing, he would look at the nurse, anything we're missing, anything we need to add. Not that we weren't interactive and doing all that, but he always made it a point to say, is there anything missing? Did we miss something? You're here, the most amount of time. So those things are important, and to have that, bleed down from there. Then he asked me to get into research, and I was super nervous about getting into research. So there was a lot of cardiac research going on at the time. Me and him and I did, which was great. And it was very eye-opening because, as a bedside nurse, you're an advocate of that patient or that one person. And when we got the results from the Milrinone study, that's when Gil said to me, he's like, now you're an advocate of thousands of kids. There's the difference. That's the difference between a researcher and a nurse. And I couldn't give it up. I had a great nurse manager, Denise Donahue. She's the VP of cardiac nursing now over at CHOP. So she's grown into her role, and she was the one that hired me. But she's an absolutely amazing woman that comes around to the units and constantly checks on us and goes out of her way, and she knows everybody's name. Saying somebody's name, even if you have to glance down at their ID badge, is huge. It's the intangible things. It makes you feel valued. I feel valued every day. I mean, I've been through ebbs and flows within Children's of Philadelphia. I've been there over 22 years in the CICU. Most of it's been per diem, like Dr. Winoski has mentioned, but I can't give it up because of the staff. I can't give it up because of the patients. I can't give it up because it gives me validity. I'm a researcher. I work at a big pharma company. And when I meet with these KOLs and these other physicians, and I tell them I still practice, that makes them turn their head at me and say, well, where do you practice? And I said, well, you probably never heard of the place, Children's of Philadelphia. And then at that point, they become a little bit more impressed. And then when you say you work in a cardiac ICU, they can't believe that I'm doing what I'm doing and still doing time there. Even my manager is great. They're great in supporting that. Like they understand the intangible things that I learned to bring back to research, because that's what's going on in the environment, academics, right? And they're the things. I don't think I'll give it up. I mean, I'm going to come up on just over 23 years, so I can't stop. And I met Gil at the beginning of my career, my nursing career, which is actually my second career. I used to work on medical equipment, so it's those little things. It was so important to me to not stop. And I call it spoon feeding myself, still giving myself the opportunity to feel like I'm making a difference in a person, a patient, a family's life, and teaching docs and teaching other new grads as they come through. It's a lot of fun. It's very rewarding. You can't put a price tag on it at the end of the day. You can't put a price tag on those things. So.
Love it. Thank you for sharing that with us, Chris.
Sure.
Jigisha?
Yeah, just to piggyback off what Christopher was saying, my story is similar in that I started off as a full-time CICU nurse, and then family life became a part of my life. And then I went to PRN, and then I stayed in PRN, and then I came back to part-time, and I stayed all on the same unit for the same reasons Christopher was mentioning. It's just, I felt needed. I felt, there was the managers, the leadership team at the time really made an effort to say, you're valuable to us, and we want you to come back in whichever manner you can, because we still believe in your practice, and we still believe in how you are practicing at the bedside. And so, just listening to the conversations today, I feel like support is the biggest, it was the most important thing to me, and that I got support, and I heard it from everyone, including the physicians, including the managers, including my nurse colleagues. And as time goes on, I think as the nursing field gets younger, there's a lot of emphasis on advanced education, which is fantastic for the profession of nursing. But I think it's valuable to bring in that need for bedside nursing is just as important, is just as valuable, and that if you stay as a bedside nurse, if you don't have the advanced degrees, it's okay, because just your time in nursing and just your love for it will show, and it will shine just as bright as someone with an advanced degree, if that's the route you choose. So I think just emphasizing that bedside nursing is very important, and just as important will, I think, retain and give nurses a purpose, which I think we all look for, because nursing is a very hard job, and it's not for everyone. I have a lot of friends who are not nurses, and just hearing, my goodness, what you do is amazing, like, rewarding. I hear words like rewarding, amazing. And it's a great feeling to know that, we've all picked a profession that truly is, it's a gift, if I can put it. And the ones that stay in longer and longer, you see how valuable their time and just how valuable the profession is overall in medicine.
Well said.
I think that really kind of circles back to Melissa's opening comments in regards to that deeper work, find that deeper meaning in your work, and how Melissa is actively coaching in any of her interactions to help have that penny drop for nurses, that it is beyond the tasks and activities. And I actually don't see that kind of focus in the organizations I've been working in to really have a deliberate strategy around that. We're all here to serve our purpose, and understanding what our why is in our work is essential. And I haven't heard it described, as you both just kind of described it in your own words today, as being a key facet around retention for nursing. I hear all sorts of other stuff. This is the first time I've heard it as clear as I've heard it from the two of you today. And that's something I actually will talk about in my course next week and try to build out. So I just really want to applaud you around helping nurses find that deeper meaning, so that they are rewarded every day through that work, regardless of the conditions that do ebb and flow around them, that they can always focus in on what their purpose is and feel fulfilled regardless of everything else. I want to thank you both for that.
And as we start to come up on the hour, we could probably talk about this all day. This could be a series, I think, of conversations, because it does extend outside of critical care. I mean, all of you have encompassed so much about the value, not only in nursing and retention, but when you look at the partnership between leaders, when you look at the leadership and staff exchange and how that impacts patient outcomes. And I focus a lot in my leadership program when we talk about retention is there are 4 key methods, but I talk about individualism. And many of you have brought up the role modeling, taking your badge off, separating self from title, and also separating the team from the individual. And then that also goes back to when you look at Patty's Nest program too, because everyone is dealing with situations differently and at a different level in different times, and also with the professional development. So there's so much of what everyone has said that has brought and encompassed in so much to the value of retention. So I really want to thank all of you today for coming on and sharing that. And I look to the group for all of you, if you have any last minute pearls or words you'd like to get out there to the audience. And also, audience, thank you for participating. It's been fantastic. And thank you, Rollis and Leah and Joanne, for catching up on the many of the comments that have come through for us. So we'll kick it off with Gil. Any last minute words of wisdom you'd like to share with the group?
I've just been so happy of all the comments of my friends on this panel. I mean, I think it's been just terrific. And Chris, your check's in the mail, man. I think the key is flattening the authority gradient and respect.
Yes.
Mutual respect across the line, and asking a bedside nurse, how can I help? What don't you, with true meaning, because if that nurse is around 3 years later, he or she is going to be such a valuable commodity and help so many patients. It's worth it. It's worth the investment, just like physicians do with fellows and other trainees. And in fact, probably better than fellows, because not all the fellows are going to go into cardiac critical care, but every nurse that I talk to has chosen that as a profession, and we want to keep them along.
Awesome. Anyone else have anything else they want to share before we conclude our session?
I think Rollis put something in the chat room. I just noticed.
One of the things I was going to say is that I think that, whether you do cardiac intensive care or you do adult critical care, whatever ICU environment you work in, and quite frankly, even if you're doing acute care nursing and you're not in an ICU environment, the work we do is grueling, it's hard, it's emotionally and physically exhausting. And there's been a lot of conversations recently about the importance of self-care and taking care of oneself in order to promote sort of, a healthy work-life balance, in order to promote longevity. I think I would take that a step further and just think about the importance of taking care of each other while we're at work. And while it's not difficult to do the things that Gil describes, asking somebody how they're doing, asking somebody what we could do better, asking somebody if they have everything they need. Those things go a really long way, and they allow us to be more resilient in an incredibly challenging environment when you're dealing with really sick kids or sick adults. And so I just end by saying that nursing retention is everybody's job, and it doesn't take a lot of effort, but we should all take care of each other. And as we do that, I think we'll reap the benefits, and ultimately our patients will benefit as well.
Well said, Darren.
I saw the question about advice to new nurses entering their first job, or
Yes.
somebody who has less than 2 years of experience. Just really quickly, one of the questions that I ask new grad nurses as I'm interviewing them for positions here is to give me an example of a time that you advocated for yourself. We spend an awful lot of time with external stimulus and external weight to try and advocate the best that we can for our patients, that we lose sight of what we need ourselves. And so you're getting burned out internally and externally. And so to be empowered to speak up if you're not understanding something, to ask for help. If you are clearly feeling burned out, I can't help you if I don't know what's happening. So advocate for yourself is a big, I feel like giving people the opportunity to say, I need help, and telling them it's okay. Not only is it okay, but it's expected, takes a lot of that burden off, and people feel better about saying, I'm not ready for this right now, or I'm not sure where to go with this. Really does a lot to make them comfortable and want to stay.
Colleen, you are going to go so far in your career. I cannot tell you. You are a natural born leader. The words coming out of your mouth right now is a breath of fresh air to many of us who have been in your position. And I could probably speak for everyone on this panel right now as well. Keep doing what you're doing. I guarantee you those two shall follow. you are a gem, and it's been such a pleasure to hear you talk on here, coming new into your position and be able to do the things that you've done. So I am so proud of you, and reach out to me anytime. I do leadership coaching. The preservation of nursing leaders and new grads is huge to me, and I love hearing you talk, and you should definitely give more speeches to anyone that's out there.
Well, thank you so much.
Yeah, no, you're amazing. So thank you for those last minute words into the program. And I just want to thank everybody else for coming onto the show. It has been such a pleasure to have all of you on the show today. And you never know, we could do a to be continued. I look forward to connecting with all of you. And what is the best way, if anyone out in the audience wanted to connect with you guys personally, which is the best method they can use? Is it LinkedIn or?
LinkedIn.
LinkedIn?
Yeah, I think that's the easiest.
Fantastic. So again, thank you so much for everybody. Thank you for those in the audience as well. And you heard the group. If you have any other questions, there's been a lot coming through about the NEST program as well. And a lot of places that would love to, steal shamelessly what that looks like and hear more about the, your research behind it. So thank you, everybody. Have an awesome day. And
thank you.
For those of you on the panel, just stay on for a few minutes because there's a little bit of a lag afterwards. So thanks, everybody.
Thanks for
everybody.
Thanks for the forum, Noelle. It was great. Thank you all. Good to see everybody.
You as well. Bye, everyone. And Jonathan, we'll just wait on your cue, okay?